In this video, we're going to talk about understanding neck pain, and we're going to dive into joint dysfunction in the upper cervical and in the lower cervical spine. Keep in mind, this is one part of a multi-part series. We put this together so you can empower yourself with knowledge to take control of your health, understand why you're having pain, and more importantly, how to resolve it, knowing when to use a conservative approach, when you need a more invasive approach. We're going to help you understand this to the T, so join us. Dr. Todd from Gonstead Spine and Wellness, located here in Meridian, Idaho. We are continuing this series talking about joint dysfunction in the upper cervical spine so you can get to the bottom of your neck pain. Let's talk about the normal anatomy in the upper neck. So that's way at the top in the picture here. We have the base of the skull, and then we have this first cervical vertebra. Notice it sticks out further than the rest of these vertebrae. That spot right there is called the transverse process of the atlas. We're going to discuss that because that's actually part of the bone that we contact when we're trying to make a specific Gonstead chiropractic adjustment, a correction to fixation or alignment in the upper neck. And then below that first cervical, which is called atlas, we have C2, which is also called axis, and then C3 and so on. And notice the relationship of the spinal cord. The spinal cord fits in a hole that goes down through the spine. That's called the spinal canal. And then the spinal cord branches off into all these spinal nerve roots. There's actually 31 pairs of spinal nerve roots that exit all the way from the base of the skull all the way to the lower part of the low back. And these nerves transverse out throughout the body. They turn into what are called peripheral nerves, and they go into every single cell, tissue, and organ all throughout the body. It's how your brain communicates with everything else. One of the ways that you can have neck pain, and in the topic of joint dysfunction in the upper neck, is having trauma, a traumatic subluxation. The word subluxation is a chiropractic word, and it's a radiological word. In chiropractic, we use it to talk about a joint that has lost proper position and motion and has certain clinical findings and could be affecting nerve function in the spine. That's the chiropractic definition. I can get more specific, but I'm going to leave it at that right now. The radiologic definition of a subluxation is a measurable misalignment on x-ray. In chiropractic, you can find a subluxation through examination findings, and then the x-ray tells us how to best fix it. So it's not necessarily a measurement on x-ray that we call a subluxation. In the Gonstead method, for example, which is the main adjusting method that we utilize in our clinic, but then we use another method called chiropractic biophysics, where we assess the curve of the spine, the alignment of the spine. We are figuring out how to fix the posture. Chiropractic biophysics has defined different types of subluxation patterns, postural distortions, abnormal shapes of the spine, of the cervical curve, for example. You're supposed to have a nice forward curve in the neck. When you lose that curve, that's problematic. We are going to discuss that in detail. This right here is showing an x-ray looking at someone this way. They're opening the mouth, and we take an x-ray. Now, we take the x-ray where the patient's facing the x-ray machine. When we get the image, we take it and we actually flip it around so that the patient's right is on the right side, left is on the left. So we're looking at the x-ray as if the person is in front of us and we're sitting behind them. Why do we do that as chiropractors? Because we're looking at someone's back. We're looking at their spine. So if we have the x-ray up and then we have the patient there, we can correlate what's going on quite easily. So that's common in chiropractic. In the medical world, they look at x-rays as if the patient is facing them. So that's one little nuance here. So this is the left, this is the right. This line right here is through some special points in axis in C2. So we put a line there to show this is the level line of C2, and then this line above it goes through a couple of light points to see where C1 is sitting on C2, and those two lines should be parallel. In this case, you can see there's a wedge on the right side. This denotes what side we're going to contact with almost certainly when we make a correction or make an adjustment. What that means is that atlas, that first cervical, has slightly deviated or been restricted up on the right side. Essentially, the joint in between the atlas and the axis, there's a little capsule in here. You can see this kind of faint line right here in between this lateral mass of atlas, the superior articular process of C2. You have it on both sides. So that little chunk is the lateral mass. You're looking at the ring of a bone that's denser on both sides of the ring. So those dense spots on both sides show up like those little rectangles. This is part of the line analysis. That's one example. This is an example of an atlas that is a left atlas. This is the Gonstead analysis. It's part part of how we look at how an atlas has deviated, and then based on the width of those lateral masses, that gives us an idea of how it could potentially be rotated. So we take the x-ray to get a listing, which is essentially coordinates of how the joint is aligned, so that if we find a problem on the patient, this tells us the best mechanical way to put a thrust into the spine in a controlled manner to try to get a good correction. Now in Gonstead, we don't take an x-ray and then find the problem on the x-ray and say, aha, that's what I'm going to go do on the patient. We always have an in-depth exam process with a patient, find the problem on the patient, and then the x-ray tells us how to fix it once we find it. And a little bit later in this, I'm going to show how we go through an exam process, and I'll talk about that step by step. Compensation, the atlas, the upper cervical spine, from a misalignment standpoint, from a pain standpoint, from a, hey, it hurts right here, doc, can you crack my neck type thing, when patients say that. We don't like when they say crack my neck. It's an adjustment, specific adjustment. Now, the upper neck, we've been taught, and I see this clinically, I've practiced now for 21 years, I see this all the time with patients. We rarely are adjusting the upper neck because it's such a common area for compensation, meaning things in the lower neck are way more common to subluxate from trauma, and then the body tries to find a level foundation so that your eyes and your ears are level to the horizon. So you could have a misalignment in the lower neck, and then the upper neck is going to try to find level, and it's going to create all these deviations and misalignments all the way up to the upper neck. Those are compensatory patterns. The upper neck is the compensation the majority of the time. That's how we look at it in our training and in our technique, and I believe that to be true. There's other chiropractic techniques that have the polar opposite type of analysis or philosophy. Upper cervical chiropractic, they only adjust the upper neck, and their philosophy is that that affects everything below, that everything below is a compensation. Now, that's more of a in-depth neurological explanation as far as how they justify that. That's not what we do, so I'm not going to speak to that. I know that they can get some phenomenal results and improvements and health benefits for their patients. It's just something that it's not our specialty. Dr. Gonstead, who started the Gonstead method, he was very adamant at having friendly debates with some of the old school upper cervical chiropractors, and he would argue that the fifth lumbar in the lower back, the very lower back, is just as important as the atlas, the first cervical, as far as assessing alignment and seeing if the person needs an adjustment. That flies in the face of an upper cervical chiropractor who thinks the upper neck is the most important. That's all that should be assessed and adjusted. This right here is showing a patient as a full spine x-ray, and you can see on the right side the pelvis is dropped on the right. That's because there's a very large leg length inequality. The right leg is short, it's dropped, the spine deviates off to the side, it compensates, and so this is a perfect example of how things down low in the foundation can affect other structures up higher to shift and have to balance out to try to keep the eyes and the ears level. If there's a shift like this, there can be back and forth deviation. Upper cervical spine is very commonly a compensation, meaning we don't adjust the upper neck very often in the Gonstead system because we find that it's not really the root cause of the problem. Now, this is a side view of the cervical spine. The green line shows where the curve should be. It should be a nice forward curve. The patient's facing this direction. The red line is where the patient is, and you can see there's a very dramatic loss of curve. This is about 127% loss of the cervical curve. That means 100% loss is when there's 0 degrees of curve. It's just straight up and down. And in this case, this is a positive 11 degree curve. That means it should be a negative 30 to 42 degree. That's the ideal normal curve. Negative just denotes that forward healthy curve. This is a positive 11 degree curve. It's completely reversed. It's going 11 degrees the wrong direction. And if we look at this next x-ray, we'll see that as this person's bending down, there's a problem in the upper cervical spine. Upper cervical doesn't just mean the atlas, which is, this is the atlas on the side view here. This is axis C2, C1, C2. But above that is the skull, and there's a joint between the skull and the atlas. This is referred to as C0, C0 and C1. And what should be happening here is that the skull is jammed into the atlas. There should be a nice space there. And when this person flexes down, the space doesn't really open up. Now, why is that happening? Well, this started as a compensation. This person had a trauma, whiplash type of injury, very likely, and it pulled the curve out of the neck. It reversed the curve. The curve reverses like this because of trauma, and the ligaments, those things that connect bone to bone, they deform, they hold the spine in this rigid position. The deep muscles have something to do with this as well as far as contracture, but it's primarily a ligament deformity from trauma that allows the curve to be harshly reversed like this. And then what happens, if you think about it, that curve's reversed, well, naturally the person will be looking down. They'd be stuck looking down. Well, they don't want to look down. They want to look and see where they're going. So they have to basically cock the skull, the occiput back to look forward, and it creates all of that squishing in the upper neck. neck, which is called extension, or in this case, it's hyperextended between the skull and the atlas. So now it's been like that for a while. Tissues will shorten, adaptive shortening. If you're in a position for a long time, the tissues will adaptively shorten. Very likely the suboccipital muscles, the muscles at the base of the skull, are in a shortened position. Those ligaments are deformed up top. And now when the person bends the head forward and they tuck their chin into the chest, instead of that joint opening up like it should, it's very restricted and stuck. That's a problem. And there's a way to intervene with this. There are protocols that we do to pry that apart, essentially. All right, so the exam presentation of a atlas or upper cervical problem, oftentimes patients are complaining of upper neck pain. When we go through an exam, we're going to palpate, we're going to feel around in the upper neck, we're going to tip the head side to side, and we're going to try very subtly feel how does atlas move in comparison to C2. When we're assessing a bone, we're assessing it how it sits on the one beneath it. So we're going to tip the neck side to side, and it should close down on both sides equally. When we feel that one side is rigid and stuck and restricted and doesn't move, that is the indication that that's the side of restriction or fixation, and that's almost always the side that we adjust as well. We match it up with the x-ray, and the x-ray is going to show what side it's wedged to, and that's going to tell us the most appropriate way to adjust. There are exceptions where we will adjust opposite of the x-ray, but in the upper cervical spine, the majority of the time, you're going to find the clinical problem on the same side as that open wedge. Now, you could feel edema, which is swelling. There's a lot of tenderness there. Sometimes it's so sensitive to the touch, someone can barely even handle it. And then there's the joint above, which is the skull and the atlas, and there's a different way to assess that, kind of a rocking movement that we do, and seeing how that joint glides, how it sits on top of atlas or C1. This right here is going to demonstrate how we adjust the atlas. This is a contact. This is an atlas adjustment. I'm contacting on the left side of that C1 on that little part that sticks out further that I was telling you about before, called a transverse process of atlas. And it's very subtle. You'll see this arm right here is putting a very minute, short amplitude, so not very deep, tiny little thrust to move that joint over. This is actually a patient that had migraine headaches for years, and this is something that helped her tremendously. This here is showing a DMX, open mouth lateral bending x-ray. We're looking to see if the first cervical, that lateral mass, if it shifts past C2. You can see here it's shifting. It's falling off the edge. We have it marked here and measured. I believe it's like 7 or 8 millimeters, which is a lot. Should be like 2 millimeters or less. 3 millimeters is a problem. This is many times over. That means there's laxity, there's stretch, potential tear of the ligaments in the upper neck, allowing it to bend over to the side. This is Caitlin. She demonstrates a normal lateral bend. So notice she bends to the side. It stays in line with C2. Doesn't move at all. We're having her position and move and test the joint. That's one of the benefits of DMX, is you can really coach the patient to move and try to see if it's gonna give, it's gonna slide, compared to severe instability. On plain film x-ray, when we try to get an x-ray like this, we have the patient open the mouth, tip them to the side, and then we have to go over and say, okay, hold still, and then push the button. The benefit of digital motion x-ray in capturing this view is that, one, this is a very hard view to get a clean shot of on x-ray, because we have to tilt the head, we have to bring the chin up to get the teeth out of the way, we have to make sure that the head's not rotated one way or the other, or we're not looking at the joint straight on. Then we have to make sure that they're fully tipped. And then the first second that you get into that tip position, there's a little bit of momentum that gets you into that position. Sometimes that will uncover slightly more translation or slippage in that moment of momentum. If you take a static x-ray, one, it's easy to miss the anatomy and miss the shot. Two, there's no momentum because they're just hanging out sitting there. So they might have sat there and then they get tired of sitting there and they kind of come off a couple degrees, and then you take the x-ray. Well, those couple degrees make the biggest difference in the world as far as identifying, is there a true instability? Is there too much movement in this upper neck? This is a very profound finding right here. It can have very severe implications. It's very important to catch and to understand. So now let's go back to the video. You see these comparisons. Now there's that big severe instability where it doesn't line up, it side slips. This is going to break it down further, and it's going to show some anatomy of what has to give to allow that bone to side slip. So watch this animation here. How the atlas slides over. It can affect the blood vessel up there. It affects the nerve up there. It can shear into the spinal cord somewhat. And this is going to flip around and zoom in on the anatomy and identify the ligaments that are compromised that allow it to slide. Okay, now you can see C1, C2 from the back, and then they have that cut away. You see the alar ligament, and essentially these ligaments can stretch and tear. That's what it's showing in this animation, for it to allow the atlas to side slip over to the side when you're laterally bending. This is a really powerful, helpful to illustrate what's going on. All right, so here's now some of the different protocols that we do. We have these specialized exercise protocols. We use a type of equipment called iron neck, funny looking hat with a type of resistance cord on it, and then we have a patient statically hold different positions and then start to rotate against resistance. There's a progression, and there's some other exercises that are done to activate activate the musculature in the neck to create the much needed stability. When it's moving too much, we want to stabilize and get it to actually move less. When there's restriction in other parts of the spine, like in the mid and lower cervical spine, which is very often in these upper cervical hypermobility issues, so it's very common, what we'll do is we will apply methods, specific chiropractic adjusting, different mobility tools to improve movement in the lower part of the neck so that essentially the upper neck doesn't have to have that additional strain, which can cause it to move even more excessively because the lower neck's not really kicking in its fair share of movement. Like when you want to get from point A to point B and you bend the head down, if this area is not moving, this is going to have to move more to get to that end range. If we can free this up, this doesn't have the same demand on it. And we do the activation exercises, and all this is patterned over and over again, and we can start to create some stability. If there's a lack of cervical curve, that also causes all kinds of chaos, so we want to improve that cervical curve and then fix all the other things that I just mentioned. This right here, again, is showing a lack of cervical curve and then that fixation top where the skull is not moving away from atlas. It's just stuck under. You see that? We have a specific protocol, cervical fixation at COC1, and we have some tools and bands and various exercises we do to really try to improve movement in that upper joint. Next up, we're going to talk about cervical cranial instability, or CCI. That's what we just showed on the DMX. There's 3 different levels of intervention as far as severity of this and how we intervene, how we treat this. So one, ideally, we can help someone conservatively, and a lot of these people we can help conservatively. We do this with adjusting the areas that are stuck, creating stability in the areas that are moving too much, making sure that the overall postural alignment is good, the good cervical curve. Big benefit of that curve is the curve allows the most ideal mechanical position for the neck to be able to support the weight of the head and to function just throughout life. So the curve is a shock absorber. It's a protective mechanism. You lose the curve, it puts more stress and strain on the joints of the spine. In a case of upper cervical stability, we want to do this conservative approach, which is a corrective chiropractic approach. The standard chiropractic approach of just adjusting someone's neck over and over again is not the conservative corrective approach. You have to have corrective exercise, traction if needed, very specific adjusting, I would argue. Where you adjust and how you adjust also matters. In the Gonstead method, there's no rotation as far as how we adjust the spine. We are moving the joint in a very neutral position. We're adjusting it from back to front because the way it primarily misaligns is it moves backwards and gets restricted, and we're trying to lift and set the joint forward. If that is not successful, or if a patient wants to do some additional means on top of that conservative approach, like they're getting result but maybe not full resolution, then the next thing would be the intermediate approach, which is something called prolotherapy and PICL procedure, which is percutaneous implantation of cervical ligaments. This is a very specialized approach. I'm going to talk about it for a second. I tell patients about this when we find upper cervical instability, that this may be the route you need to go. We will usually send people out to Colorado to the Centeno Schultz Clinic because they are the ones that pretty much pioneered this technique. I'm going to show you what it is. This technique involves getting injections in the upper neck. It's putting stem cells in the upper neck. I listed out prolotherapy. I'll talk about that first. What's prolotherapy? Prolotherapy is like a dextrose type solution, like a sugar solution that you inject into tissue, usually into ligament areas, to try to create an inflammatory process. And as a result of the inflammatory process, it lays down tissue to create stiffness, pull in various markers from our body's healing mechanisms to draw the attention to the area to induce or trigger healing. Now, the issue is if someone is putting needles in your neck, especially in the upper neck, you see these blood vessels here, they better be really, really careful and have guided imaging and have ways of actually identifying these vessels with typically a type of dye even, so that they make sure they're not injecting any of these solutions into a blood vessel. You do that in the neck and that goes up to the brain, that can cause all kinds of problems. That could even kill someone. This has to be done very carefully under very precise imaging, and just do not trust anyone to do this. It needs to be guided by imaging. So that's prolotherapy. The PICL uses stem cells, which is a different mechanism that's trying to use cells that will regenerate ligament and promote healing, cells that can differentiate into tissue that is needed, such as a stem cell. That's what's so special about stem cell. It's a type of regenerative medicine. So now in a severe instability like this, that's where someone could go through that procedure. This is showing what they do at the Centeno Schultz Clinic in Colorado. Those 2 yellow dots, that's actually where they come in with a needle through the mouth. This is a surgical procedure in the sense that the patient is asleep. You're not awake when you do this. And they even specialize 3D printed these mouthpieces to get really good, accurate alignment and placement. And they use live fluoro. So essentially this is called a C arm because it looks like a big C. And they're taking images as they go real time because they're guiding the needle in there. And then they even use a dye, and they'll put a dye in here or a contrast. This is the needle showing injecting contrast contrast, and then stem cells into the damaged ligaments in the upper neck through the mouth. That's what the PICL procedure is. That's at Centeno Schultz Clinic. The third level of invasiveness to help stabilize an upper cervical spine, I mean, this is like when someone's life is just destroyed because of this. And these are some of the cases that are out there. It's quite awful. When there's massive upper cervical instability, it can be so bad that you can rest your head on a pillow and it's shifting your atlas, and it affects your nervous system and spinal cord in such a way that your blood pressure can jump up 20, 30 points systolic. Your heart feels like it's beating out of your chest. You feel like you're walking around in a cloud. You can't function. People that are really bad with this, they're desperate to even try a surgery if they're recommended for it, but the surgery is very harsh, and I would leave that as an absolute last resort, because the surgery is a fusion surgery where they're going to essentially put screws or a fixation device between C1 and C2 and lock it together. I'll show you a couple of examples of that. This is one called the Brooks method, where we take wire, almost like baling wire, like they're putting together a fence, and then they put some bone in between there, and then it fuses together. So this is another shot of it. You can see there's a screw coming up this way. That is a screw fixation, a pedicle screw fixation. And then this is showing what some of the imaging looks like when you have that hardware in the upper neck. That happens, you can't move that joint ever again. And most of the rotation, most of the turning movement in your neck comes from C1 rotating on C2. So you're not going to move normally if you have this type of surgery. This is a last resort. Next, we're going to talk about mid and lower cervical spine. So the normal anatomy of the lower neck, we talked about this in depth in a previous video where we went to anatomy and ligament. So if you haven't watched that one, you should go check that out. But there's some differences between the mid cervical and the lower cervical. It gets larger as it goes into the lower neck, as it transitions into the thoracic spine or the mid back. Traumatic subluxation can cause dysfunction and then pain in the lower neck. Typically a whiplash type of injury is going to affect the mid and lower cervical spine. And let's just think about this. The neck is fairly unsupported as far as anything else in the spine, meaning it's smaller in diameter and there's just muscle and there's smaller vertebra, and that's all there is to really hold it together, and ligament and all of that, of course. But it's a much less stabilized structure that then transitions into a really stable and planted thoracic spine. You now have these 12 ribs coming out and you have this big sturdy thoracic spine. So the point in which the neck transitions into the thoracic spine, that's called the cervical thoracic junction. That is the most common area to find damage in a flexion extension or a whiplash type of injury. And in the Gonstead method, we're taught, and I'll tell you in clinical reality, we see this all the time, the vast majority of neck problems throughout C6, C7, or T1. That's also one of the hardest areas to adjust properly because of where it's at in the body. Most chiropractic methods use a lot of rotational adjustments. Very hard to rotate that part of the spine and get a good correction or a good adjustment. Gonstead method, we adjust the neck primarily in the seated position. We're setting the bone forward. We're lifting and setting it forward because it's misaligning backwards and tipping down into extension. We're lifting and setting it forward with very little to no rotation. Or we put a patient face down on a high-low table prone, and we're lifting and setting that segment forward. And I'll show you what that looks like here. Let's talk about the exam presentation first. This is how this looks on exam. This is how we identify a problem here. There's going to be a reading at least upper cervical. Pretty decent break there, lower neck. It's coming out. Sometimes it'll take 3-4 times before we start to see a pattern of where that little needle breaks. I'm going to mark this up. Breaks over to the left. So what I'm doing is I'm using an instrument that measures temperature from side to side. This is part of the Gonstead method. We use instrumentation. The process of what we're looking for when we're trying to find a subluxation or a joint that's problematic that we're likely going to be adjusting is we use an instrument first. We use a skin marking pencil to denote where we found a temperature differential. So a reading with an instrument. So we're measuring temperature and it might deflect at one level and then it might deviate right back to center. Well, that quick deflection and rebound, that's indicative that something's going on. There's a different temperature from side to side and from level to level. And it's very helpful as far as in identifying levels of concern as far as the joints in the spine. It's one of a several part system to find subluxation, find the problem. In the Gonstead method, we're putting more emphasis into finding the problem than just jumping in and starting to move bones. So we check with this little instrument. You can see she's holding an iPad so she can actually see what I'm seeing, which is helpful for the patient. Movement of your neck. That's the first thing we'll look at. Let me put this down. So next what I'm doing is I'm palpating for movement. I'm going to tip you side to side because as a joint misaligns or gets stuck, subluxated, it gets fixated. It swells. There's swelling in the joint at the disc around the facet joints, which in a later presentation, we're going to do a deep dive into the facets and how those can cause pain and dysfunction and how those need to be worked on or addressed. I'm palpating. I'm feeling for edema, which is swelling that comes from the joint. I'm feeling for fixation and I'm getting feedback from the patient as far as point tenderness. Those are all things that give me an idea of where we're likely going going to be working. Tipping you, going on to C2. Tender?
A little tender.
Tender here on that left upper. Okay, so left C2, Jenna, tender on the left. Not really too restricted though. You actually feel like you move a lot in your upper neck, which I'm guessing just looking at your posture, what's likely going to happen, we're going to find, is you'll be more restricted and dysfunctional in your lower neck and more compensatory, like moving excessively in your upper neck. With how your posture is projected, where your head comes forward, and then the fact that you feel so flexible in this upper neck, that's likely what's going on. And believe it or not, this is one of those cases where flexibility and ability to move so much is not necessarily your friend. It can lead to something called instability, which means a joint moves too much and then it's more prone to injury because there's not enough protection.
All right, go ahead and bend that head as far forward as you can and really push it.
This is showing flexion, extension x-rays. Like
go ahead and relax.
You'll notice in the x-rays, there's those little white dots. Those dots are BBs. We tape the BBs on the surface of the skin. We do the exam first, and based on when we find something on exam, we'll tape BBs to denote different exam findings so that we can take what we found on exam, look at what we're seeing mechanically on the x-ray, and then put 2 and 2 together to have a very great understanding of what we need to do to help the patient. This now shows the adjusting. So let me play this and then I'll comment. Well, I'm actually commenting in this video. So I'm commenting on me commenting. In this case, I'm adjusting C7, which is the 7th vertebra. So if we have 1, 2, 3, 4, 5, 6, 7, I'm adjusting C7 compared to the foundation of T1, T2, T3, everything below that. Technically, my stabilizing hand wants to stabilize the side of the neck below the segment in which I'm adjusting. So I'm adjusting C7. Well, the next vertebra below C7 is T1. I want to be stabilizing down to T1 the best that I can, so that as I'm adjusting this, I'm adjusting C7 as it pertains to the foundation, the segment that it sits on below, which is T1. And really the tip of my finger here on my left hand is contacting underneath that spinous process, slightly to the left side of it, but right underneath it. And the goal is to lift and set the bone forward. And if I do so successfully, her head should come up and forward like this and not like this. If it turns when I adjust her, that means I'm slightly spinning that vertebra. I'm rotating that vertebra, which is what we don't want to do. Just adjusting. Boom. We lift and set that vertebra forward. And she said, I love that. That's amazing. Okay, watch. Let's check out another one. Not gonna turn her head clockwise. So this is the Gonstead seated cervical adjustment. One of the things that the Gonstead method is famous for. She's a more flexible patient, so this is not the cleanest looking adjustment. My forearm should be pointed more forward, but I had to do a little bit more lateral to medial contact, but then the thrust is straight forward. She's more flexible. I have this strap over the shoulder. She's strapped into a special chair called a cervical chair. That helps stabilize so that I can actually put a lighter, more focused thrust into the spine. It's not rotating a joint and locking out a joint and then rotating it further. It's using timing when the patient's relaxed and you have that split second window to just lift and set that bone forward, almost sneak it into place. It should come straight forward. Her nose should tip up. So let's just see that in slow motion. The hand does this. Watch, I'm going to show you. You can kind of see this with the hand. It does this. It radially deviates. This is your radius. This deviation is radial deviation. You're throwing it like this. You're supinating, so you're turning the hand open and radially deviating. And that's where a lot of that power comes from.
There you go.
On to the next one. And up a little. A flick, bringing it forward. Nice. You did good. Big smile. Next one. Lift your chin. So with this, same thing, I'm telling them, lift your chin. And as they lift their chin a little bit, it opens that vertebra up, also takes their mind off of contracting, anticipating, and then very quick, explosive. It's a light contact right before we deliver that adjustment. It's the difference between the Gonstead seated cervical adjustment. You can watch all over YouTube and find all kinds of crazy rotation and pulling on the head with a towel and pulling with the Y strap. I made a video on the YouTube channel about the Y strap, not a fan. This is a very controlled, specific adjustment. And these are all lower cervical adjustments. These are all like C7, T1 levels. More intervention. This is Trainer Tony. Worked at our clinic for several years and we still see him periodically and he stars in videos. He's doing a head translation traction right here. We're pulling the head from right to left to correct a head translation posture. We cover this on a future section of this video series. It's going to go right into curve correction traction on the side view, everything we've been talking about so far. This here is a seated unit used to increase or decrease the curve in different parts of the body. In this case, we're going to increase the neck curve. Position that where it's comfortable. This one right here is pulling the head back, and this one right here is bending a forward curve into the cervical spine, exactly what trainer Tony needs. This here is a seated unit used to increase or All right, this is showing again, reverse cervical curve. There's Carly over here doing traction. She's got this pad, it's covered on the chin to make that comfortable, and then this bar right there, it's a spreader bar. There's a rope behind that. That rope has then a thin neoprene sleeve that contacts right into the neck. You need that fulcrum in the neck to create the bend, because if you just bend the head back, this is the spine here just bending back, so extending. Notice there's no curve in the neck. It's just straight bend backwards. It doesn't naturally curve when you bend the head back. It's stuck. It needs a fulcrum pulling directly forward in the plane line of these lower discs in the neck. That's the direction of pull to create curvature. So you see the outline of that neoprene sleeve on the neck traction pulling forward, inducing more of a nice curve. Last one here, as far as intervention, we talked about some conservative intervention, things that we do. Not pictured here is the different types of exercise we do to reinforce this and some of the different stability and strengthening. Let's show right here a surgical approach. This is Dr. Tim Johans. He's one of the longest practicing neurosurgeons here in the Boise Meridian area. I've known him over the years. I've been in the operating room with him probably on over 20 surgeries observing. I've had a handful of patients that were surgical cases. He took great care of them. He's an awesome surgeon. I think he's one of the best. If I needed a spinal surgery, he'd be the guy I'd be consulting with. We had permission to be able to go into the operating room and film a video, film actually multiple surgeries. And so we did this. And so you'll see a video of me putting a microphone on him. I'm miking him up and I'm taking video, and we capture clips of this for educational purposes. And right now we can show it off, and I can show you what happens when someone has a mid to lower cervical joint dysfunction. They had a bad curve in almost all of these cases. And these times I've been in the operating room, they'll have pictures of their x-ray and MRI, and I look at it almost every single time. There's a cervical kyphosis, a reverse cervical curve. And there's all this osteoarthritis in the joints where the joints start to get destroyed and they break down. And then there's a disc herniation, or there's bone that develops that starts to put pressure into a nerve. And now this person's having massive symptoms, nerve compression, with severe pain, numbness, tingling, weakness, loss of neurological reflexes. And now it's determined that they're going to go have surgery, that they need surgery. Some of those cases might be able to respond conservatively, or they've already exhausted it. But either way, at this point, they're doing a surgical correction to decompress the nerve. And you have to change the structure of the spine to get to that point. I'll explain a little bit.
I'm not good looking like Grey's Anatomy now. Number 14,000 or something at this point. You don't want to drop soapy water all over the OR floor because people fall. We'll say that.
So that's me right there, putting a microphone on him.
Scissors, please. A significant blood supply that's coming up through the vertebral body. But when I get close to dainty neurologic structures like nerves or spinal cord, use that bipolar electric pulse.
The majority of the surgery, they're going in and just trying to do a clean dissection, get through the tissues, not harm anything so they can access the spine. They go through the front of the spine. So this is an anterior approach. Once they get to the front, they're moving other structures out of the way, like windpipe. Essentially, they're exposing the front of the neck, and then they're identifying which ones need to have pressure come off the nerve. They have to drill holes through the bone, and then they use this spreading device you'll see in a second, which almost acts like a little hijack, pulls that up, and then they go in with a handheld tool, and he starts to basically tear off chunks of the disc from the front of the neck, goes all the way through the vertebra to the back of the neck, and now he's on the front surface of the spinal cord, spinal nerves. So you're basically cutting through the neck from the throat, peeling everything out, scooping out all the stuff that's irritating the nerve, and they cut everything out of the way. Now you've decompressed the nerve. Well, now you can't just close the person up because now that joint's not stable anymore. So in these cases, you have to put this little spacer piece in between that locks in place, and then a plate on the front, and there's some bone grafting material in there, and now you're fusing those two bones that once moved, you're fusing them together into a block, and that fixes the problem as far as the pressure off the nerve, but it creates another problem. And now that you have a fusion, and then the joints above and below have to move excessively to make up for that loss of motion. Dr. Johans tries to do essentially joint replacements as much as possible, so arthroplasties. One of the main guys that really pushes for that in the cervical spine when someone's a candidate. Sometimes people aren't candidates for the joint replacement in the neck and they need to do a fusion. Big differentiating factors, and the person has a lot of neck pain, and if the facets or those posterior joints, which there's a whole video we have just on facet, so if you want to know more about that, that's in the series as well. That will be covered. But what happens if the person has a lot of facet pain or pain with motion, then you can decompress the nerve, and if you put a joint arthroplasty in it, that person's going to still have severe pain probably for the rest of your life. So fusing the joint will stop it from moving and thus stop the pain, but then it causes those other mechanical problems. I'll play the rest of this so you can see.
At 2 levels, and then it'll allow me to spread these open at the disc level to allow me to see a little bit better. And the view is everything in surgery. There's my 2 vertebral screws, you can see, in cervical 4, one's in cervical 5. So I put this instrument over them, then I open it up. The right spot. All right. First thing I do is I take a plate. We've used the preoperative films to get a pretty good idea of how long it will probably be. I need to be longer, about 4 millimeters. So when I do arthroplasty, those have to be perfect. So an arthroplasty surgery requires more skill, more training, and more precision than a fusion. Now we get to close. I always consider the neck as part of the face. I try and be really kind as far as the cosmetics of it all. Women appreciate it.
Everybody does these,
Yeah.
Everybody appreciates it. That's been quite enlightening and helpful approach to be able to see it firsthand and really see the skill of what these surgeons are doing. Again, that's Dr. Tim Johans, and he's one of the longest practicing spinal surgeons, neurosurgeons here in town. Does a lot of specialization with the cervical spine, and he tries to be as conservative as possible, and he's very supportive of our style of chiropractic. He's actually referred patients to us. It's kind of unheard of to have a neurosurgeon referring patients to a chiropractor. He and I work really well together because he understands what we do and he believes in it. And when someone needs a surgery, I believe he's a good person to consult with. All right, there you have it. We just covered joint dysfunction of the upper cervical, mid and lower cervical, how that causes all kinds of types of pain, how we treat this, different treatment options. If you found this helpful, please share this with a friend, family member, coworker, neighbor, someone. There's people out there suffering that need this information. And I invite you to watch the other videos in this series as well. If you'd like to get checked out and go through an assessment and an analysis to see if you're a candidate for our care, information will be listed below. When it comes to the health of you and your family, results matter most. Thanks for watching. Make sure you like, share, comment. We'll see you on the next one.
Video presentation by Meridian Gonstead Spine and Wellness of Meridian, Idaho. Our practice is dedicated to people suffering from neck pain, low back pain, tension headaches, migraine headaches, herniated discs, and leg pain such as sciatic. We have treatment protocols for musculoskeletal aches and pains, joint pain and dysfunction, and whiplash injury. Gonstead Spine and Wellness offers a distinctive chiropractic experience. It is the only office in Idaho with digital motion x-ray technology. And this advanced imaging tool, combined with the Gonstead spinal analysis and necessary radiographs, enables precise identification of spinal issues. We provide safe and effective Gonstead adjustments, corrective care through chiropractic biophysics to enhance and sustain proper posture, and a 12-week transformation program. This program includes access to a comprehensive video exercise library for ongoing home support, ensuring long-term health and wellness. Call us at 208-888-6077, where results matter most.